Okay, so good morning, everyone. We have a new grand rounds today. This time is going to be Dr. Peter Kaplan. Before starting, I just want to mention to everyone to please use your full name in the Zoom so we can have the record of the assistance. Additionally to this, you can find the link to the previous presentations. It's in the chat. So going back to Dr. Kaplan, that is going to be our special guest today. I can tell that he is going to be giving us a presentation about EEG and toxic-metabolic encephalopathy. Dr. Kaplan, as a quick introduction, he grew up in Switzerland. He had training, basically medical school in London in the St. Bartholomew Medical College. He also has training in Duke neurology and also fellowship in EEG and epilepsy at Duke. He has been faculty at Johns Hopkins since 1987 and has been professor of neurology, and he's also a very prolific academic production with articles, books, and other uh, production. So I can also mention some of his hobbies, travel, Sherlock Holmes, and crystallized minerals. So we are very grateful to have Dr. Kaplan today to talk us about this very interesting topic. So Dr. Kaplan, all the spotlight for you.
All right, thank you. Can you hear me?
Yes, very clear.
Yes, we can.
Good, all right. Well, first of all, I'd like to thank Sergio for inviting me to give this lecture, and thank you all for coming at a relatively early hour. I'm going to talk about the EEG of toxic metabolic encephalopathy or delirium. One point on that, for neurologists in the United States, encephalopathy is the word used for confusional states, whereas in the rest of the world and in psychiatry, delirium is the term, but you should probably think of them as roughly the same thing. Now, you are in your training certainly well versed in images that you see on CT and MRI, and they sound or look certainly more intuitive in trying to understand them. The EEG, though, of course, is a tool which shows a different aspect of neuronal function and reflects metabolism. And it is something that's somewhat less familiar, probably because trying to interpret squiggles versus a picture is just a less intuitive prospect. But I'm going to take you through the different patterns and emphasize in what ways EEG is revealing and show you many of the different aspects. We are often put off by EEG because the report may say, this pattern is etiologically non-specific. So you feel when you get that, well, everything looks alike and how does it help differentiate? But you should think of EEG as a triage tool to determine whether the patient in fact is awake but simulating, and it has a normal EEG, or diffuse slowing if it's encephalopathic, or sleep patterns if they are in fact too sleepy, or non-convulsive patterns if they have that. So let me already move on and take you to, let's see. Sorry. Let's just get. All right. We will cover then the aspect on EEG and touch on prognosis. We will look at the shapes of the waveforms, which is morphology, frequency, reactivity, and amplitude. And we will look at some epileptiform features and how we correlate with the clinical picture. So encephalopathy actually is hugely important, and it makes up of hospitalized patients, as you can see in general hospitals, up to a quarter. But as you look at the bottom of this list, that somewhere above 60 in the frail elderly, medical ICUs up to 80, and advanced cancer up to 90. So it is a bit of an iceberg in terms of how prevalent it is versus how much we recognize it and try and investigate it. The causes, and this is based on my work at Bayview, largely are the first 4 ones here, and the rest, 5 through 10, are less frequent, although encountered regularly on an annual basis. So the ones most commonly seen are the polypharmacy from either the medication burden that the patient is on, particularly if they're elderly, or intoxications that may be illicit. Then there's the next group of organ failures that will produce metabolic or electrolyte abnormalities, whether it's renal, hepatic, respiratory, cardiac, endocrine, or others. And you can see those in 3, which is organized by organ per se, and 2, which is the consequences of these organ failures. And finally, 4 is the infections. So one way of looking at EEG, and it was the way it was investigated in the past, was to look at the evolution downwards as the patient had decreased levels of responsiveness or cognition. And the EEG was classified into these 4 groups to make it simple: mild, moderate, moderately severe, and severe. And you can glance through these things, but essentially what it is a progression down the frequency scale from alpha, theta, delta, and also a change in the voltage. Initially, you can have higher voltage slow activity, but eventually you will have suppression. So what we have encountered then, as you see, is that you have a waking rhythm, the alpha rhythm, which can be seen in mild encephalopathies, or indeed clinical encephalopathies can have normal EEGs. But when you get to more moderate ones, you are seeing a replacement of the alpha frequencies by theta, and down below that, delta activity, usually with a mixture of theta and some alpha. So it's not a strict sort of black and white switch from one frequency to the next. It's a gradation. The classification for coma, there are several. The Canadian group has done one, but CINEC is perhaps the most widely accepted, where it's been graded into these 5 gradations, and this has been looked at specifically with the etiology of anoxia, because that's the one we're most interested in prognosticating. Why? Because anoxia often produces irreversible change, whereas almost all other gradations, let's say, and typically you look at anesthesia, these are all reversible. So you can go all the way down to flatline, but be totally reversible. So largely, the prognosis depends on the irreversibility of the insult and therefore the etiology. So it was important to be able to predict what happened when people were anoxic. So in this study by Scolo-Lavizzari, as you can see with the numbers of patients, the grades that you saw before, 1, 2, 3, 4, and 5, even with mostly alpha, if you are in coma for more than 6 hours after anoxia, then really about 80% had a good prognosis, but there clearly 21% didn't, even though they had alpha. And then 50% had a guarded prognosis, even with the grade 2 of theta. You're down to a quarter when you get to the delta, but the lower grades had pretty much 0. And this has been more recently refined by a number of publications that sort of look at other aspects than just grading 4 and 5. So let me show you this. Here you can see in the second here, an eye blink artifact. And after that, the appearance of the alpha rhythm, 4 on the left, 4 on the right, going front to back, posterior basic rhythm. The alpha is reactive to eye opening and closure. And therefore, this is a predominantly symmetric, normal, reactive alpha, and that has a good prognosis. Now, here you're beginning to see some changes, and you have a broken up posterior basic rhythm. There are more slower frequencies intruding in here, and this would be more theta with some alpha and correspond to a grade 2. This is a more pervasive, diffuse 5 hertz pattern, in other words, diffuse theta. And again, this would reflect the grade 2 of an anoxic pattern. In this case, though, this was due to hypoglycemia. This is now with a lot of polymorphic slow activity. You can see there's a mixture of this delta here with faster theta, would correspond to the delta pattern, the grade 3. And now we're going down to some of the worst grades. The electrocerebral inactivity, which is flat. I'll touch on alpha coma, burst suppression patterns at the end, and very low voltage, almost flat EEGs. This is one that is pretty much flat. All you see is the ECG or EKG artifact sometimes, but you can see even at a recording sensitivity, which is much increased in gain, it largely is a flat record. And that would carry, and this is truly flat, no prognosis for return of consciousness after anoxia. Now, you can look at different encephalopathy patterns by where we understand the EEG patterns that are abnormal to be generated. So, for example, if you're looking at one of the two patterns here, alpha coma and spindle coma, what these are due in alpha coma is to hypoxia of the cortical laminar areas, but also, in fact, involvement of the pontomesencephalic junction, where you have interruption of the ascending arousal systems through the brainstem and thalamus, and it interrupts them so that it's the cortex that produces an independent, non-modifiable, in other words, an alpha coma or an alpha rhythm, which is not reactive. And the similar idea is that here, if you have pontomesencephalic damage, then the thalamus continues to produce via its sleep circuits spindles that resemble sleep, but you cannot get through to this thalamus because of the damage, and therefore it's an unarousable sleep pattern. Alpha coma, first described quite a long time ago, consists of alpha frequency activity, but what is different from alpha waking is that it's more diffuse and, in fact, sometimes more dominant anteriorly, and it is really typically unreactive. When I looked at the total group of the world literature on it some time ago, the 335 cases, what became evident is that the etiology didn't depend on just the coma pattern, alpha coma. It depended on the etiology causing the coma. And that really underlies pretty much all of the outcome studies in most EEG patterns. It's the cause of coma that predominates. So if you had anoxia, then 88% died. Brainstem infarct, 90% died. Drug intoxication, only 8%. Now here you can see the patient pinch toes and call. You still see all these alpha frequency patterns, in fact, anteriorly predominant, which are unreactive to the noxious stimulus. If you look at spindle coma, again, described a long time ago, you get sleep-like patterns or architecture with spindles superimposed on what could be viewed as vertex sharp waves or delta activity. And you can see it on a routine EEG. Looking at the meta-analysis of the 242 cases that were prevalent, here it was a much better prognosis because, in fact, if you looked at drugs, seizures, or encephalopathy as a cause of spindle coma, 0% died. Trauma, 15%. Hypoxia, 33%. So only a third of them died, which for hypoxic insult is relatively good, a good prognosis. Probably because this represents sparing of all the circuits from the thalamus to the cortex to be able to get this pattern. Now, more recently, you have, for example, the use of EEG to look for independent functional outcomes. And this was a study that you're encouraged to look at in the Annals of Neurology last year, where cardiac arrest, they looked at coma patients, they looked at spectral analysis. And what they found, and I'll show you a burst suppression pattern, was that among the bursts, there was quite a bit of theta activity, theta, between bursts and with the bursts. And when these patients with this burst suppression post-anoxic pattern had this pattern, then the prognosis was in fact favorable. All right, let's look at anatomic origin. This was the schematic I showed you before, but here it's broken down by particular EEG patterns. Theta pattern is mostly produced by slowing of the cortex by the poisons that you get with uremia, hepatic disease, or other toxins. Now, you can also, since these faster alpha and theta patterns are produced by the cortex, you can have chronic conditions such as cortical atrophy and Alzheimer's disease producing a remarkably similar theta. So it doesn't distinguish between acute and chronic and reversible and irreversible. Getting to the theta delta, it's usually a deeper lesion that affects the white matter, in which the ascending volleys from the thalamus are deafferented from the cortex. So what you get is projected slow activity. Triphasic waves somewhat similar, but in volleys, and I'll show you that later, going to this cortical surface, and as I showed you, the alpha and spindle coma. So you can therefore classify it into cortical, as you can see here with these waveform changes, subcortical, as I showed you before with the schematic, and then brainstem problems. Now here, I wanted to show you what one of the spindle comas look like. And here you can see the spindle itself, and it's riding on top of slow delta activity, which resembles, in fact, a vertex sharp wave. And this resembles a K complex. So it looks like sleep, but from which the patient is unarousable. You can pinch the patient and nothing improves in the EEG. You can look at the EEG by frequency. Some toxicities, such as benzodiazepine barbiturates or other withdrawal states, will produce excess beta. If you see the eye blink here and here and here, you'll notice this fuzzy activity that is seen in sort of spindle shape, but much faster. It's pervasively all over, but actually in this case, is more predominant in the frontocentral areas, which are the areas that more typically can produce beta activity. So this would be an indication of that sort of intoxication, the fastest frequency being beta. Now, we already showed you alpha and alpha coma. Now let's look at the mild or level 2 anoxic ones. And here's the theta pattern, again, cortical mantle, and also more generalized involvement of the neuraxis. And here we had the example of the patient with hypoglycemia. Going down the scale of frequency, you have polymorphic delta. This is the history of how it was determined and where they thought it was generated. It was deafferentation of the subcortical white matter by the work of Glure in cats in Montreal. And it's generated, though, also by pyramidal neurons. And if you see here, its involvement at this level of the neuraxis, and this is what it looks like. This is the 10-second one in which you can see extremely high voltage polymorphic delta, which sort of waxes and wanes and is admixed with some alpha or theta frequencies. But you can see the marked anterior, and in this case, high voltage delta. I view these as sort of pictures, not just as waveforms, because it's a gestalt. We look at sort of voltage, we look at how broadly it's distributed, and we look at frequency and form a mental picture of what this EEG looks like. You can have more continuous rhythmic delta that doesn't wax and wane with deep-seated epileptic foci and limbic encephalitis. And so here you can see a much more rhythmic pattern of the delta activity as it goes along. And in this patient, it varied between 2 Hertz and 4 Hertz. And this sort of shifted from side to side over the left frontal and right frontal region. And that was a patient who had limbic encephalitis and was in fact in limbic status, and it broke with a benzodiazepine. But this, to all intents and purposes, looks like an encephalopathy. It does not look like seizure activity. Intermittent rhythmic delta activity is a pattern that used to be thought to be very common in the elderly and have any number of contributing possible encephalopathies. Here it is. It's this pattern here of delta waves seen intermittently. It's seen here, and then for 2.5 seconds, it's gone. Then it comes for another 2.5 seconds, and it's gone. And it's bilateral, frontal, and intermittent. Now, the important thing, as I said before, is the reversibility of the etiology of the coma. And that is reflected in the EEG, in which you get reactive. In other words, if you stimulate the patient and the brainstem is in contact with the cortex, the EEG is reactive. and it shows that you haven't damaged widespread areas irreversibly of the neuraxis or even reversibly. Here's a good example. So this is narcosis with CO2 in a patient who had a PCO2 of 107, and here's how it reflects it. You can see in the first second with muscle artifact over the forehead that there's an eye blink, an eye shut. But here in that second, you actually see normal alpha frequency posteriorly, and it's reactive because here it's not so well seen, and now it's seen. But what's remarkable is as soon as you close the eyes, within half a second, the patient goes into a very high voltage delta pattern. So this is typical of some, but few, highly reversible effects of metabolites, in this case, PCO2, because you can either excite the patient out of it and stimulate them so that this no longer produces the narcosis momentarily and they'll relapse into it. But it's not like having a uremia, in which case, no matter how hard you try, you will not be able to get in a patient with this sort of slow activity an alpha pattern on stimulation. So what we've then come to learn is that clearly there have to be correlations between the imaging studies and the EEG pattern. So for example, in this patient, there is theta activity, and here the CT is not that revealing, but this is the patient with the hypoglycemia, and acutely hypoglycemia will not produce changes in many patients, so you see a normal CT scan. Here, for example, you see a patient with deep midline it's a rhombencephalic involvement, and there's swelling, and therefore there's interruption of the ascending pathways of arousal. And what you indeed see is after the eye blink, the patient is more awake, but as you stop stimulating, they slow down. So this shows again, and this is how EEG can be helpful, the reactivity of the EEG to stimuli reflecting interruptions in arousal mechanisms. Because the cortex is relatively preserved, so the patient's cortex is producing relatively normal EEG. In limbic encephalopathy with this pattern here, you can see bursts of bilateral delta that I showed you before, and that's probably a reflection of the fact that these are deep-seated foci, so by the time it gets to the cortical surface, the spike component is not seen. You can see it in some patients with the extreme delta brush or even spikes, but often you won't. In this example, you can see a mixture of white matter disease and some gray matter disease. And what you see, therefore, is this intrusion of slow activity here, 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 here. But intermittently, there is some faster activity because the cortex is also spared. So it's a dynamic with stimulating the patient or the spontaneous change of the EEG, a mixture of slow delta and slow theta. This is an example of a patient with hydrocephalus and multiple metabolic problems. Here you see up here. And what there are these interesting waves that have an antero-posterior lag. It occurs earlier here in this 1 second piece, and then it goes posteriorly. And this waveform is maximal in the frontocentral region, not in the frontopolar, which is more anterior. And our understanding now is how these are generated, and I'll show you how these triphasic waves, which were typical of metabolic encephalopathies and carry a prognosis of 20% mortality overall, are generated. Here you have polymorphic delta, and this is raised intracranial pressure and is producing global brain compromise. And that's why, again, you're getting more delta activity. So now we're beginning to unravel the fact that these patterns aren't all etiologically nonspecific, but are dynamic and reflect different degrees and levels of compromise of the central nervous system. So to investigate this further, what we did in my hospital is we took all the EEG recordings and subdivided them. So the ascertainment is that they had to be referred for the EEG. And we looked at bins of patients. In other words, Were they predominantly theta, more than 50% theta of an epoch of the whole EEG, or a mixture, or delta, or triphasic waves, to try and see what the imaging correlation was? And here's the bottom line, is that brain atrophy, cortical atrophy, went along then with theta frequencies, whereas intracranial hemorrhage with coma produced more delta activity, as did PRESS. And if you had a past stroke, this enlightened us that FERTA, in fact, was not usually diffuse dysfunctions from uremia, but more the fact that the patient was elderly and had a focal stroke. Let's show you some of these correlations. Here you see the cortical atrophy, whereas the subcortical areas are relatively spared. And as you can see, the alpha is a little bit lower voltage and is slow. This is not the normal 8 to 10 hertz alpha. If you look at this intracranial hemorrhage, where again, there's pressure being exerted outwards, but the cortex is spared, you have the fact that between these eye blinks, you have cortical activity, but there's sudden episodes of slowing because of the raised intracranial pressure. So in a way, you can follow the patient in some aspects with an EEG, looking for change in compromise, because this reflects typically the level of consciousness. This imaging does indirectly, but is not a direct measure of metabolic function. Here you have PRESS and white matter disease. And there again, you can see high voltage delta intermittently as the reflection of the subcortical compromise. Here you have that very focal ischemic stroke, and that's where you get the intermittent rhythmic delta activity that you can see here. Now, encephalopathy overall that you'll encounter in the hospital is actually, if it's due to drugs, these are the ones that Cataldo wrote an excellent article on, and you can see what I encounter more is benzos and opioids. I can't say I see that many people with corticosteroid encephalopathy in terms of numbers. But as you can see, in his article is excellent, there are over 100 drugs that can cause encephalopathy, which when I do consults, I can only remember a handful, but it's worth having to hand a list of them because they are often anticholinergic or other, and it's as simple as trying to find out which mixture of multiple drugs or which single drug may be responsible. And usually you have multiple simultaneous causes of encephalopathy when you get an EEG pattern that is encephalopathic. So if you look at that frontal intermittent rhythmic delta activity, and you look at the contribution that's structural, all right, so you have 23% here, which, 33%, which are purely structural. And then you have the ones here which are purely infectious, or the ones that are combined infectious and structural. You understand the Venn diagram, how they overlap. And you can see the overlapping is a different pattern somewhat. Here, triphasics are usually a mixture in a third of the patients of all three insults, all right, infectious, metabolic, and structural. Now, if you look at the morphology, this is the triphasic wave that I was showing you earlier. Antero-posterior lag. This is the time base, so it occurs earlier here and a little bit later here. Now, they're not all morphologically similar like clones. Like this one has this phase reversal, which is a bit unusual. But typically, you have a very minor first phase of the so-called triphasic waves, a big second wave, and a big third wave. And mostly with the typical triphasics, they are not anterior here, they're frontocentral. So let's show you a few others. This is the schematic, which illustrates why you get these waves from a traveling wave of depolarization over the surface of the thalamus. So if the surface of the thalamus is depolarizing from front to back, and it sends a volley of activity that goes to the cortical surface, you will see the wave appear here first, then here, then here, then here, as the volley goes along. You can have conditions that excite the posterior thalamus, and then the traveling volley goes anteriorly. So you can have both anterior and posterior origins of triphasic waves. So although also described a long time ago, it's actually very interesting because of what it is telling us now about the etiologies which can cause it. But as I said, reversible causes have a better prognosis, but overall 30% mortality. Now, you may have seen or gotten reports on your patients that cefepime causes triphasic waves. So this may be a signal that not only does cefepime cause more of these morphological encephalopathic patterns, but that cefepime confers and carries with it, because of that triphasic morphology, it connotes a greater mortality. And this remains to be explored because, as you know, cefepime is being used widely for any number of infections. And I can tell you that cefepime is probably the second overall cause of triphasics in my lab. And remember, patients are referred because they have altered mental status. Now, you can have triphasic waves either purely from these insults. You remember hepatic encephalopathy, uremia, anoxia, toxins. But in fact, in the elderly and people with white matter disease, you can have relatively mild insults and produce triphasic waves, suggesting that there's a deafferentation between the thalamus and the cortex, which facilitates these projected rhythms. So let's show you this. This is hyperammonemia. And again, you have these sort of regular triphasic waves, and the CT correlate doesn't show marked changes. In lithium toxicity, you will see less well-developed waves, but they are often spikier and they come and go. But nonetheless, this can often be called triphasic. And it's worth knowing, particularly if the patient's on lithium, that they don't have to be toxic on the lithium, they can be high therapeutic. And that would suggest that this being a toxicity, and you look at the different causes or medicines the patient is on, that it's the lithium that's responsible. You can normalize these things. You can normalize sodium, lithium, urea, and all that, but the EEG lags behind. Why? Because the EEG reflects the actual clinical state of the patient, not just the normalization of the blood, because stuff is happening in the brain and the encephalopathy is only beginning to regress even as you normalize the blood. Baclofen can produce these sharp triphasic waves, again, a little bit sharper, spikier than others, and we've seen a handful of Baclofen toxicity. Some with overdoses, purposeful or not. This is cefepime, and you can say they are much blunter and flatter, but this is so commonly seen now that I expect that you will encounter this in your patients. Sometimes it's confused for non-convulsive status epilepticus. In this one, anoxia, these ones look so metronomic that it's a bit of a giveaway that it's anoxia, in the sense that more dynamic reversible ones are a little bit more subject to reactivity and spontaneous change. This is the fixed insult producing anoxia, triphasic waves. But again, if you have slight renal compromise, pregabalin can produce it. Aztreonam, we noticed recently, and I've seen it with gabapentin. So of course, the idea is to be vigilant, see any drugs that are the patient has that may not be cleared adequately because the patient is small or elderly, and the renal clearance is not sufficient to get rid of the medication, even though the measurable level or even the dosage appears to be okay. So we looked also at the triphasic waves, since they are such a striking feature of encephalopathy with that high mortality. And again, we saw that a full third of the patients had all three contributions. You can get them purely from structural, purely from metabolic, but really it's the straw that breaks the camel's back. And they really have to have a lot of these things to produce these patterns. So we looked at the prognostic significance, and again, the mortality in that cohort was 20%, but 32% of the patients had all three insults among infection, metabolic, and structural. Periodic discharges, I'll just give you a nod because they are an EEG pattern that is associated with altered mental status and hence an encephalopathy. And as you know, historically, they used to be called lateralized, and that was the L, bilateral independent, generalized with the G, and stimulus induced. But there's an E here, which has since been taken out because it was felt that they weren't necessarily epileptiform. They are just periodic, focal, generalized, or stimulatable. And let me show you an excellent schematic by Chong and Hirsch, which illustrates his conceptualization, and I think it's valid. When you look at the likely interictal to ictal potential of that pattern, and also compare the danger of neuronal damage, because you want to treat patients who have high risk of neuronal damage, but not necessarily those with low, particularly with anti-seizure medicine. So here are the triphasic waves, which acutely don't connote or confer neuronal damage, and triphasics may be an epiphenomenon of already damaged brain that's predisposed to it. Pleds, GPADs, bipleds, and then you have non-convulsive status, epilepticus, and generalized convulsive. So that's an excellent schematic to think about. This, first 4 on the left, next 4 on the right. You can see the periodic discharge over the right hemisphere, frontally and temporally. So that would be a pled, typically caused by strokes, infections, or even trauma. Here you see bilateral independent discharges. This one occurred here. This one occurred about 400 milliseconds earlier. And this is typically due to bilateral insults of the brain. And they each have epileptogenicity and have their own firing rate because they are disconnected, one insult from the other, left from right. And this would be produced by metastases or multiple infections, or indeed, again, head trauma. With generalized rhythmic delta activity, you can see that pattern bilaterally here. But periodic discharges that are generalized, you can see that they go front, not always front to back, but certainly pretty broadly in each hemisphere and largely synchronous. This is a pattern which is highly helpful. It's bad, it's post-anoxic, but here's the key feature. You'll notice the shape of these complexes are identical. And this is called generalized bursts with identical morphology. And Van Putten in the Netherlands showed that 100% of his cohort and other published cohorts were invariably had a poor outcome, vegetative state or fatal. So this is the worst prognosis of the periodic discharges. Here you have burst suppression. Beware that this is not due to anesthesia, because that's totally reversible. As I said before, if you have theta patterns among them, then it would be a slightly better prognosis. But burst suppression patterns are bilateral and synchronous, but they can vary from that to something that looks like this, a whole series of brief ones, or they sort of flutter where they have little polyspikes and then there's a pause and they build up and they go away. So it's more the fact that they are bilateral and synchronous, but you can have variations on rhythmicity throughout and also variations on the spike patterns. Here you see up here what looks like a seizure, and indeed was. The patient had a tonic-clonic, or rather a clonic event, and then went into a suppression pattern, then had the burst suppression, and then it started again. So these things evolve one into the other, not specifically etiologically linked, but this is typical of anoxia. This, if you notice, are these generalized periodic discharges, but if you have twitching, it is called seizure, or epileptic seizure, sorry, it's called with the correlate that it isn't just an EEG finding, you can call it a seizure, and this pattern would be called status if it continues, all right? And of course, once you hear status, you tend to react differently in terms of your management than if this is just periodic discharges. This is more obvious because the patient is not only jerking, but the frequency of these discharges exceeds 2.5 per second. And that is the cutoff point, at least for non-convulsive status. And again, that was a guess. It arguably now is if you have anything above 1 per second could be considered non-convulsive status. Here's 3 per second, and again, that would be managed more obviously as status epilepticus. This, however, is a post-anoxic patient who had seizures, and post-anoxic seizures and status has a very grim prognosis, with the exception of this pattern in which you see a lot of intervening faster activity, and the patient has fully normal brainstem reflexes and an image, a CT or an MRI that does not show pervasive damage. So if you have a relatively normal image and you have these intervening activity and you have brainstem reflexes present, and here's a bit of an alpha, then this actually can have a normal outcome. So 5 out of 200 patients had this sort of pattern, and they stuck with it, and the patient did well. So in summary, you use EEG for triage, to exclude seizures, to establish prognosis. And we looked at all these different measurements that you can do on the EEG waveforms. A lot more can be done with quantitative EEG or looking more thoroughly at particular diagnoses and looking at the EEG of those patterns. And what we do clinically, since I do consults a quarter of the year and EEG throughout the year, I have the advantage of being able to do more immediate EEG to clinical to imaging correlate, and therefore tighten up perhaps some idea of what's going on and what needs to be done. Thank you very much.
Thank you, Dr. Kaplan. That was an excellent lecture. So now we're open the mic for questions from the audience.
And do speak loudly, because I'm a bit hard of hearing. Giorgio, will you read out any questions, should there be any on the chat?
There is no question so far from the chat. Let me see.
Okay. Well, I agree. It's all a bit bewildering, and EEG is not the sexiest of aspects of neurology, but as you can see, it can be helpful in the global management of patients with altered mental status. You know, typically some of the people who are just coming to neurology, when they see someone with altered mental status, will order a head CT scan. And typically, structural abnormalities that are focal with preserved brainstem do not produce relevant explanations of why the patient has mild alteration. The study of choice is not the head CT or the MRI, it's actually the EEG, for the reasons that it will triage between factitious, sleep, non-convulsive status, and encephalopathy. And then you can go a little bit further. The other interesting thing is that the EEG pattern that you've seen when there are several different insults reflects the most predominant one that is clouding your clinical picture. All right. So if the patient has
a question.
Yeah.
Does the spectral representation of the EEG add anything? Is that a helpful way to look at it compared to the traditional way?
Well, it is, in the sense that you can test the reactivity of the EEG, and it shows often whether the patient's brain, in effect, is reactive or whether the EEG alters spontaneously. And it gives you an idea also of how deeply compromised, and I showed you the schematic of the neuraxis, where the problem that actually is affecting the patient lies. You can have imaging that show all sorts of things at multiple levels, but the EEG reflects the most serious level. You know, I have a lot of patients who are on multiple drugs, and they're being given cefepime, for example, and they have borderline renal function. And I usually encourage them to, as quickly as possible, switch cefepime for something else. And then the delirium, the encephalopathy, over hours, more days, resolves.
Okay. Dr. Kaplan, there are some questions actually coming from the chat. The first question is from Dr. Weiss, and it's mentioned, so GPDs of greater than 2.5 hertz are considered diagnostic for status epilepticus. If you see LPDs at greater than 2.5 hertz, is this also diagnostic for focal status epilepticus?
Well, so two caveats. The international colloquium on status epilepticus that produced these criteria, the EEG criteria of non-convulsive status, was actually my workshop with others. And we came up with that because we thought that that encompassed the likelihood. It's not a real evidence-based thing. It's more of a gestalt that those ones that we saw, we believed you had to do a cutoff. There's more recent data, though, that is better. And that is that you produce metabolic damage even at discharge rates as slow as 1 per second if you do a PET or SPECT scan. You can see increased flow. So probably we'd have to revise it downwards. And in fact, PLEDs can produce that. So the idea of a certain cutoff at 2.5 per second, I think it's more important to see what the clinical correlate of the patient is. Because you can have 2.5 per second with a patient who is actually almost normal and talking to you. And in those patients, I would obviously be reluctant to put them in diazepam or propofol coma. So I go by the clinical level of consciousness, the etiology, and the EEG to decide how intensively to treat the person. The other point I would make is that triphasics to some people look like GPEDs, and they are subclassified as a variant of GPEDs. But the journal that's coming out in a week, the Red Journal of Clinical Neurophysiology, outlines how you can distinguish triphasic waves from GPEDs. And GPEDs that are frequent could be classified, as I said, as non-convulsive status, but triphasic waves really should never be treated, managed, or classified as non-convulsive status.
Okay, there's another question. This is coming from one of our residents. Is if you can explain a little bit better the difference between the bilateral intermittent discharges and burst suppression.
The difference between burst suppression and bilateral
intermittent discharges.
So they're just probably different words used to express the same thing. The classification for EEGers shows that the suppression between those bursts is less than the measurable 20 microvolts. The bursts, though, can be typically they're high voltage, but they can be any voltage, any frequency, and any morphology. But it's that sort of on-off aspect of being suppressed and then having bursts. You can have bursts without marked suppression between. You can have bursts on normal voltage background. So that, that would be intermittent bursts would be probably a better way of describing it. You have to add the word generalized synchronous bursts, though. Burst suppression is always bilateral synchronous.
Okay, Dr. Kaplan, there is one question actually coming for Dr. Grant.
Yeah.
He says, nice to see you. And he's asking, can you comment on what EEG features for an EEG in the interetal continuum make you learn more one way or the other than frequency of the discharges?
All right, so the interictal continuum was a term coined when they realized that patients may start by having a few discharges, but have, let's say, epilepsy and not be actively having seizures. So that's interictal, but very sporadic, all the way to what the other question was, which is you have frequent discharges that can go even faster than 2.5 hertz, let's say 6 hertz. And somewhere along that line, you have to make a clinical decision on how intensively to treat. So that's the continuum that goes from interictal all the way to ictal. Ictal is obvious if there's the clinical correlate of movement, which is a bit of a factitious finding, because there's no reason to believe that if you just happen to spare the motor cortex, but you have the same sort of insult to other areas, it isn't equally damaging. So efforts are being made, therefore, to sort of determine when to intensively treat with anesthesia. And usually what we do is we fold in the cause and the level of consciousness into the EEG pattern to make a determination of how morbid we think it is. So for example, if you have frequent discharges and the patient has had as a cause intracranial or extracranial hemorrhage or stroke, then there are evidence that treating intensively improves outcome. If you have patients who have some of these discharges, but they have much more benign findings, let's say they are even in absence status, those are not brain damaging, and therefore you will tread more lightly in treating it. So it's not the EEG where it stands along the continuum in isolation, it's what's causing it and how deeply obtunded the patient is. So let's take a typical scenario, ICU, no clinical exam because the patient is paralyzed and under anesthesia, and the cause of the status of the event, let's say, is head trauma. Then if you see independent seizures or you see generalized discharges that are probably anywhere above 1 per second, I think there's reasonably good evidence to not only give non-sedating anti-epileptic drugs, IV this, that, or the other, but also to, with the anesthesia, to include one of the 3 major ones like midazolam or propofol. So I think nowadays there's data that suggests 1 per second. This has come out of the Harvard group. And the way they illustrated that, the Columbia group showed that if you had a microelectrode that you produced evidence of brain damage, and they looked at different patterns. And the Harvard group looked at functional measurement of reflecting brain damage. And they also found that when you got above about 1 per second, you were beginning to produce measurable change. So that's where I think it now lies.
Dr. Kaplan, there's another question also coming from the chat. Is one of our residents. So it comes like this. So frequently, when we have a report of triphasic waves, we do not treat aggressively. But with such high mortality in triphasic waves, should we try to improve triphasic waves more aggressively? And has the mortality been adjusted to the underlying cause? Or is the mortality just a reflection of the severity underlying problem that caused triphasic waves, thus increasing the mortality?
So when we did our 9-year cohort, we found no association with how many triphasics, how high they were. But there was, and there wasn't even a correlation with the level of consciousness, because often these were done in patients who were already obtunded for other reasons. So it was disguised. But the only thing that we can do about it, because we can't really effectively improve triphasic waves and their effect by giving benzodiazepines, they will momentarily go away. In other words, you have triphasic waves, you give IV Valium, they will go away, but that's only because you've altered the level of consciousness of the patient. This is evidenced by the fact that if you then give a sternal rub, once they've gone away, then the triphasics almost immediately come back with arousal. So it's a state change that causes them to go away. It's not an anti-epileptic effect of benzodiazepines. So there doesn't seem to be much promise in trying to treat them with something that makes the waves go away. And benzos are the only thing that does that actively. It's treating the underlying cause of the triphasics, which seems to be the only thing that we could modify.
Okay, is there any other questions from the audience? I think, Dr. Kaplan, this is most of the questions. This is a very a good lecture to us, and really appreciate all the time that you gave us for preparing, give us this lecture. It was a really wonderful lecture.
Well, thank you all for hanging in there. It was a pleasure presenting to you, and I hope you get some ideas for work that could be done on a clinical basis.
Yes, it's very wonderful. Thank you so much, Dr. Kaplan.
You're welcome. My pleasure.